3, timing. What did I tell you? 90 days. So we want to saturate, if we're going to schedule contact of support. Do we have some people that need a call twice a day the first 5 days they're out of treatment? And don't tell me, well, they can't because they ain't got no phone. They all got cell phones. Ain't no drug addict worth their salt that ain't got a cell phone. Don't tell me that. I ain't saying they're legal, but they got cell phones. Okay, intensity. Can we not only focus on that first window, and as they do well, we begin to titrate down the contact. We go from daily to twice a week to once a week, right? But we're constant, checking in and encouraging and coaching and praising. And then we go to twice a month and once a month. And then we call on that once a month call, and Bernie sounds like hell today. Flat affect. How'd you sleep last night? Haven't slept. And what are we getting? We're getting all these ugly signs. Sound like vegetative depression. No appetite. Haven't used, but I've been thinking a lot about using. What we got to do? We're calling at noon. I want to talk to Bernie about what he can do in the next 2 hours to feel better. Because I'm calling him in 2 hours to check on whether those things worked. And if not, we're going to keep working. We're going to keep problem solving that day. And by the way, Bernie, is it okay if maybe I'm worried about you? Can I check on you? Can I give you a call tomorrow morning? And what am I doing? I was now decreasing contact, and now in this period of crisis, I'm dramatically escalating the intensity of that. And as soon as he restabilizes, guess what I'm going to do? Praise, encourage, it's going to go back down over time. But I also know, and part of that's that 90 days. I got to get him through that 90-day window of vulnerability. Can any client also tell you times to put on the calendar that they're going to need some extra support? I'm serious. Know thyself. Look at your life the past 5 years, and you tell me, in the next 6 months, what are the dates I should mark on the calendar that I should be calling you? And we should be trying to get together maybe even. And you know what they're going to talk about? Man, 4th of July with my family. I ain't got through one of them sober ever. So we need to do something around the 4th of July. I know I'm going to be vulnerable anytime I either start a new relationship or I break up in a relationship. Some people are very fond of particular dates. You know, the anniversary of their 4th or 5th divorce that was very special to them, right? May be hard to get through. I don't care what it is, but they can tell you that. So we make that part of the schedule. Recovery. When we go from the treatment plan to the recovery plan, what we're going to begin to do is almost as part of the recovery plan, the client's going to tell us, we're not telling the client what he needs to do with continuing care. He's telling us what he needs by way of support in the coming months. Now, what we generally say is the first 90 days is automatic. And beyond that, let's talk. And we're going to put a schedule together, and they're going to request when they want us. Number 5, duration. What we say, continuity of contact over time with the primary recovery support specialist, preferably the same person when that's possible. Now, having said that, I need to tell you the Achilles heel in this entire model is right here. Tell me what staff turnover is in addiction treatment in the United States. Now, I want you to think. Some of you have been blessed because some of you got chronic disorders, like me. I got a couple of them. And I've been very blessed to have the same physicians, and they monitor me all the time. I got to do blood count checks like more than I even want to think about. Same people with me all the time. And some of you got primary care physicians that have taken you through long, long courses of keeping some of this stuff stable. That's the ideal model. But in our world with the turnover of addiction treatment, we can't guarantee that, can we? What we're hoping is that we're going to be able to develop a stable of recovery coaches, that the quality of satisfaction in their work will be high enough to dramatically lower the turnover in those roles. And you know what? We got it right now. Because in a lot of the places that we're beginning to implement these, the recovery rate for addiction counselors is twice as high as that we're seeing with recovery coaches. So we're hoping we will, to the greatest extent possible, we're going to be able to do that continuity. I think at a practical level, some of this we're going to have to do in teams. to be able to assure continuity of contact over an extended period of time. Location, community-based versus clinic-based, meaning we're really talking about, rather than inviting people back for continuing care, we're talking about how do we get a presence in their life. What do you think the most underutilized post-treatment recovery contact for adolescents is right now, today? You said it. Who said it? Texting. Texting. How important are cell phones in the lives of adolescents in the United States right now? If you want to, how viable would online recovery support groups be? And monitoring systems that also integrate text messaging as part of the encouragement and support process. We need to, that's what we're talking about, is rather than saying, invite all the adolescents to come back for group today, the question is how do we take ourselves and inject them in the lives of those adolescents where they're at to encourage recovery stability. Staffing can be provided by professionals or it can be done in a peer-based volunteer format. Technology, increased use of telephone and internet. Okay. Oh, do I want to go through all these studies? All I can tell you is we're rigorously doing all kinds of studies about recovery checkups, and I don't have much time, so I'm just going to tell you we're getting significant outcomes. If you want to lower post-treatment relapse, develop systematic schedules of post-treatment recovery checkups. Even if you're not going to do the aggressive kind of monitoring that I talk about. I mean, think about it. What we're getting significant effects on quarterly telephone-based and interview-based, face-to-face interview-based checkups. Now, we need to think about, we're violating my first principle, which is what? Saturate support in the first 90 days. So at the end of the 90 days when we call, where are we at? We're at the end of the period they needed the greatest amount of support. And we're still getting effects just from doing that. What do you think it would be if we aggressively did the early and then titrated that down to quarterly, or in some cases as we get out to 4 and 5 years, maybe an annual checkup? Oh, let's go to number 8, relationships with recovery communities. Let's look at this.